Hi, my name is Dr. Catherine Lai. I'm at the University of Pennsylvania. I'm an associate professor and the physician leader of our leukemia clinical research unit. And I moderated the rapid oral session that was on Friday that looked at MDS, leukemia, and transplant patients. And what I think are some of the interesting abstracts that were presented in particular was one for newly diagnosed older pH-positive ALL patients presented by Dr. Luskin, looking at the combination of asatinib plus dasatinib in addition to blinatumomab for these patients. And what was interesting was that after their first cycle of blinatumomab, 100% of the patients were in a CR, but also an MRD negative CR. The other abstract presented by Dr. Mascarenhas looking at intermediate and high-risk MF patients who were treated with ruxolitinib and the addition of imetelstat improved their symptoms, specifically splenomegaly, but importantly also saw a reduction in their variant allele fraction of their mutations, which highlights that maybe there might be some underlying change to the disease biology. There were some really interesting questions that were brought up. I think two of the studies, the first by Dr. Garcia-Manero, which was looking at the long-term results of luspatercept compared to ESA for treatment-naive, low-risk MDS patients. It showed that the patients receiving luspatercept had an improvement in overall survival, which this is one of the first studies to report that, so that was very interesting. Also, Dr. Goldfinger presented some data looking at metronomic dosing of decitabine with venetoclax in MDS as well as AML patients, and in particularly, it seems that the TP53-mutated patients had a particularly high response, and we know that this patient population is extremely difficult to treat. In terms of the future, I think that the past has shown us that adding more drugs improves efficacy and improves response rates, but that there seems to be more toxicity when we are adding agents together. And so I think being thoughtful about timing as well as combination and sequencing, I think we will be adding more drugs into the regimen. So, it's a discussion of triplets, but how do we do that safely that maximizes the response rate while also minimizing the toxicity for the patients?